Men at risk for prostate cancer are Black or African American men. They have about a 1 in 6 chance of developing prostate cancer in their lifetime. Also, men with a primary relative that has prostate cancer, so that's a father or a brother, are at increased risk of having prostate cancer. Along those lines, we have noticed that there are genetic mutations that are handed down through families that can increase one's risk for prostate cancer. And one of the newest and most common is the BRCA gene, which we commonly associate with ovarian and breast cancer, and we're actually finding that men in those families are at increased risk of prostate cancer as well. So these are the patients that we really need to focus our screening on and screen these patients every year and very carefully. And these are the patients that should not be left to semi-annual, every 3-year screening. We need to screen these patients every year. If someone is having symptoms from prostate cancer, unfortunately, it's generally an advanced prostate cancer. So the prostate is an organ that sits underneath the bladder. So one of the first symptoms that one might have is blood in the urine or difficulty going to the bathroom. Another symptom is if the cancer has spread. And generally when prostate cancer spreads, it goes to the lower back. So some men will have lower back pain. Another symptom may be swelling in the legs for some men, and that's because prostate cancer tends to spread to the lymph nodes in the pelvis, which the lymph nodes are little cleaning pods, I like to say, that run along with blood vessels to clean them of any infections or inflammation that they may have. Cancer also tends to spread via the lymph nodes, and they can get very enlarged and therefore block the blood vessels coming up from the legs, and men can get leg swelling from that. So it could be blood in the urine, difficulty with urination, back pain, leg swelling. But again, these are generally symptoms of well-advanced prostate cancer. And thankfully, because of PSA, we don't see that as often anymore. Something that is frequently said, and that is true, is that most men in their life will get prostate cancer. That's not a question. The question is it going to be a prostate cancer that is going to affect you in your life? So it is a natural part of aging, and it happens in most men. But the key is to find the cells that will become lethal to you, and that's finding it earlier on in life. Most PSAs in America are checked by primary care physicians. So that is the place to start if you want to get your PSA checked. If you have any other further questions, or if there's any question about your PSA potentially being a little bit higher than you think it should be, go and get a second opinion from a urologist. We won't necessarily take you right to get a biopsy that day and then operate on your prostate the next day. That's not what we do anymore. Our job is to, number one, see if you even need a biopsy, and then if you do get a biopsy that's positive, to give you all of the options, one of which could include active surveillance, not doing anything right now until it gets worse. Primarily, you should seek getting your PSA checked by your primary care doctor, or at least ask them about it. If you have further questions about it, then come to a urologist. Some primary care physicians will check a PSA automatically every year, and some won't, because PSA screening is not meant for every man every year. However, if you are at higher risk of prostate cancer, if you have a family history, if you are Black, if you have a history of ovarian or breast cancer, which could imply that you have a BRCA mutation, you should seriously ask your primary care doctor about getting a PSA. At least have that discussion. If you want further discussion with it, then come to a urologist, and we'll talk to you more about the pros and cons of PSA screening. We recommend that all men between 55 and 70 have a frank discussion with their primary care physician or urologist about PSA screening, because that is the age at highest risk of having prostate cancer. If you yourself are at high risk of having prostate cancer, so you have a family history, African American, BRCA2 mutation in your family, you should be screened, and you should be given that option. And if you're not, then you should seek a second opinion. If you don't have any of those risk factors, it may not be necessary, but having one PSA checked can't hurt. If there's any question about that PSA being high, then go see a urologist, and you don't necessarily need a biopsy. But there are plenty of men without those risk factors that get serious prostate cancer. So that's why I would recommend that all men get at least one PSA checked in their life. An elevated PSA does not necessarily mean that you have prostate cancer. It is just a red flag that we should look into this further. It stands for prostate-specific antigen, but is not prostate cancer-specific. So if a man has an enlarged prostate, they'll tend to have a higher PSA. Older men tend to have higher PSAs. So when the PSA reaches above a certain amount, or it looks like it's rising from what it used to be, they'll generally get sent to us or another urologist to look into that further. The first thing I do is to recheck the PSA because it may be a false positive. The second thing I do is look at the trend of the PSA. Has it been going up at a steady pace? Has it been going up very sharply? If I'm suspicious at all, we can get further tests at that point. Some of these tests aren't for all patients, but we can get specialized PSA tests like a 4K score. We can get urinary tests that can actually look for shedded cancer DNA products in the urine. And what I think is one of our strongest diagnostic tools in prostate cancer right now is getting an MRI of the prostate. And that's a very specialized MRI that very few centers do, and we at Georgetown have been doing for over 10 years now. An MRI can pick up very high-risk prostate cancers, the ones that we want to find and we want to treat aggressively. If an MRI is negative, that doesn't mean that prostate cancer isn't there, but it may be one of the slower-growing prostate cancers that we don't necessarily have to treat. So if you have an elevated PSA, I'll probably work that up with an MRI afterwards. If the MRI is negative, we may still have to proceed to the next step. If it's positive, we'll definitely proceed to the next step. If we've decided that the next best step is to do a prostate biopsy to get that diagnosis of prostate cancer, patients can be assured that at MedStar Georgetown University Hospital, you are going to get the newest technology with the best results of the biopsy and the fewest complications. And that's because 2 years ago, we introduced a newer form of biopsy that we can do in the office called a transperineal prostate biopsy. So this has reduced the risk of infections almost to 0%, which was a problem with the old types of biopsies or other types of biopsies, and also increased our diagnostic yield. We actually noticed that we can sample a lot more of the prostate this way than we could with the way we used to do the biopsies. In addition, with the MRIs that we get at Georgetown, we can use those to pinpoint where we want to focus our biopsies to make sure that the patient gets an accurate diagnosis. One of the most common questions I get is, what is a normal PSA? If I'm taking a test or I need to give you an answer or what's on that, the lab form will say that a normal PSA should be less than 4, but it is not that easy. Patients at different ages have different PSA levels. So all of that comes into play. When someone comes in with a PSA level to me, all that matters to me is how old you are and what were your past PSAs, and not necessarily a total PSA level. Because a PSA of 2 may be considered normal in an older man who's in his 60s. A PSA of 2 in a man in his 40s is not normal. But if we use that cutoff of a 4, then we would be missing a potential prostate cancer in that young patient. So the normal PSA is individualized for each patient based on how old they are, also how big their prostate is, and also if they have any other symptoms. If they're having burning with urination, it could be a false elevation because of an infection. So for me, it's more the trend in your PSA and if that trend changes. So each person in general will have their own baseline PSA that I will follow over time. Now, there are some PSAs that are very worrisome. Any PSA over 10 is certainly worrisome. But when you get to saying that a normal PSA is below 4 and above 4, it's much more nuanced than that. Annual PSA screening is not for everybody. However, I do advocate that every man gets at least one PSA checked in their lifetime. Now, PSA screening for every single man every year is probably too much, because there are a lot of men that will not be at high risk for cancer, and they may get a diagnosis of a very low risk cancer, and that may lead to a very aggressive treatment that's not needed. So that's why I say it's not for everybody. However, for high risk men, black men, men with a family history of prostate cancer, men that have the BRCA2 gene, they need to be screened every year. So the general recommendations of the American Urologic Association are that all men at least have a discussion with their primary care physician or urologist about PSA screening, the pros and cons, whether they should get it between ages 50 and 70. That's for the general population. Again, for men at risk, black men, men with a family history, men with BRCA2 gene, they should be screened every year in that age group from 55 to 70, probably even earlier. We would advocate that those men get checked starting in their 40s, either age 40 to 45, depending on which guidelines you follow. I also advocate what's called the baseline PSA, and that's what I recommend every man should get in his 40s. Some men may get aggressive prostate cancers without any of these risk factors, and we see that unfortunately all too often. And just checking one PSA in their 40s may have prevented that. So what's called the baseline PSA is just checking a single PSA level in all men in their 40s. If that PSA is over 1 to 1.2, they're considered a higher risk, and those are patients that I check every year. I put them in the same group as all the other men with high-risk prostate cancer, and I check every year. If that PSA is less than 1 and they don't have any other risk factors, they don't have to worry about PSA screening every year until they're 55. And then when they reach that age from 55 to 70, when prostate cancer is most common, they can get it checked every year to 2 to 3 years, but it does not have to be done every year. So the key to prostate cancer screening is not, let's not screen anybody. It's not, let's screen everybody. It's, let's screen the people that are at high risk and do it selectively and do it intelligently. If I get a patient that has a family history of BRCA2 gene, we will send them to our excellent genetic counselors at Lombardi Cancer Center, who will then do a full profile, genetic risk profile. And if they come back with the BRCA2 mutation, that's when we'll start screening them very thoroughly. PSA is the main intro screening test, which leads to a red flag to maybe get what I call second level PSA testing. And that can include blood tests that add on to the PSA that is more specific for prostate cancer, less specific for, say, enlarged prostate or prostate inflammation. And that can include a 4K score, a PHI or prostate health index. That can include a urinary test that detects DNA, tumor DNA in the urine called an exosome DX. So in some patients where I'm on the fence whether we should proceed with getting a biopsy or not, those are the type of tests that I would get. And I would also consider getting an MRI in those patients.